Good afternoon. My name is Natasha Udelli, and I want to welcome you to the NIH Office of Disease Prevention Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to provoke the use of the best available methods and support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Natasha. Today's speaker is Dr. Elizabeth Selbin. Dr. Selbin is Professor of Epidemiology at the Johns Hopkins Bloomberg School of Public Health and holds a joint appointment in the School of Medicine. She's the author or co-author of over 350 papers in the peer-reviewed literature, including landmark papers in the New England Journal of Medicine, JAMA, Lancet, Annals of Internal Medicine, Diabetes, Circulation, and other major medical journals. Dr. Selbin has devoted her career to leading translational research projects designed to evaluate and improve screening, diagnosis, and patient care for people with diabetes. Her work has directly influenced clinical practice guidelines for diagnosis and management of diabetes. In 2013, she was awarded the Henry Keene Memorial Award by the International Diabetes Epidemiology Group of the International Diabetes Federation for her contributions to the field. She is the 2020 winner of the Kelly M. West Award for Outstanding Achievement in Epidemiology from the American Diabetes Association. From the start of her academic career, Dr. Selbin has been continually funded as a principal investigator on grants from the National Institutes of Health. She has mentored or co-mentored over 40 students and fellows, many of whom are now leaders in the field. It is my pleasure to welcome Dr. Elizabeth Selbin.
Thank you very much, Dr. Murray. Hello, everyone. I'm delighted to participate in this webinar series and present to you today some of my research and discuss the importance of the screening and of epidemiology and the screening and diagnosis of diabetes. These are the three most common tests of hyperglycemia that we're used to seeing: fasting glucose, 2-hour glucose, or glucose measured after a standardized carbohydrate challenge, otherwise known as the oral glucose tolerance test, and also hemoglobin A1C. These are the three tests that are routinely used in clinical practice, although fasting glucose and hemoglobin A1C are much more common in the setting of the screening and diagnosis of diabetes. Hemoglobin A1C differs from glucose in that it is an indirect measure of hyperglycemia. Glucose binds to your hemoglobin in red blood cells, forming glycated hemoglobin, and because your red blood cells turn over approximately every 120 days, you can measure the proportion of hemoglobin that is glycated, or the proportion of hemoglobin that has glucose bound to it. And this gives you a measure of average glucose exposure over the prior 2 to 3 months. So a nice property of hemoglobin A1C is that it's a measure of chronic glucose exposure and is stable over time. Here's a table I put together comparing these three tests of hyperglycemia. I want to draw your attention to this column here. These are within person coefficients of variation. This is a measure of the 2-week total variability of each of these different measures. One thing to notice is that glucose has a coefficient of variation of just under 6%. 2-hour glucose has a coefficient of variation of almost 17%. And hemoglobin A1C has a coefficient of variation of less than 4%. So that is, hemoglobin A1C has the lowest within person variability and is the most stable of these three measures over time. So that means my hemoglobin A1C measured today is likely to be identical or very similar to my hemoglobin A1C measured 2 weeks from now. It is also the stability that makes hemoglobin A1C attractive from an epidemiologic standpoint. It tracks very well in individuals over time. Okay, so stepping back a little today, so I'm going to talk about diagnostic tests. So what is a diagnostic test? A diagnostic test is a test that classifies individuals with signs and symptoms as having the disease or not. So a diagnostic test requires a high probability that the test is correct. And we're talking about the classification of individuals, not the statistical distinction of group averages. In patients in whom the diagnostic test is applied, our overall goals are to improve health outcomes and reduce suffering. So overall, we want to do more good than harm. What is a screening test? A screening test is a test that classifies apparently healthy individuals as likely to have the disease or not. In diabetes, our screening and diagnostic tests are the same tests, but we might apply them differently depending on whether we're using them for screening or whether we're using them for diagnosis. Okay, this is the only slide I'm going to show that is not about diabetes, but this is some historical data of reactions to the tuberculosis skin test. So this is a graph showing the skin reaction to the purified protein derivative or PPD test in a population of adults. And you can see the frequency distribution of the skin reactions measured in diameters of induration. So that's the skin reaction on your arm here from the PPD test. So the first thing to notice about this graph is that it's bimodal. So there are two peaks. There appear to be two populations of individuals. So one group with low values and one group with high values. And if you notice, a value of 10 millimeters of induration divides this population into two groups, into those with low values and those with high values. And as it turns out, 10 millimeters of induration is often used to define a positive result on the PPD screening test. So what's interesting here is that the distribution of test results themselves help inform our understanding of screening and help us come up with a definition for a positive test. So on the other hand, many human characteristics, things like blood pressure, glucose, 2-hour glucose, hemoglobin A1C, cholesterol, these are the measures that are central in my field. These have continuous scales. And the distribution of the biological measurements themselves don't permit us to easily separate diseased from non-diseased individuals on the basis of the value of the measurement. So ideally, we'd like our biological measurements to result in a bimodal distribution, right? So we have a test value, a diagnostic test value that completely separates the population perfectly into those with the disease from those without the disease. In practice, things look much more like the bottom figure. In my world of chronic disease epidemiology, the distribution looks much more like this. You have a distribution of the biomarker in those with the disease, and you have a distribution of the biomarker in those without the disease, and these two groups overlap. So where you draw the cutoff value, or where you draw the line to define a positive test, creates a trade-off between false positives and false negatives. So a biostatistician might tell you, putting people into boxes like this, saying one person is positive, one person is negative, is highly inefficient. It's associated with a substantial loss of power. And you might ask, if risk is on a continuum, why not just use biomarkers along a continuum? Well, the answer to that question is that we need to draw lines in the sand because cut points are necessary in clinical practice. We need to define people as having the disease or not because making a diagnosis is fundamental to clinical care. Everything flows from that diagnosis. Without a diagnosis, we cannot make treatment decisions. We can't discuss prognosis, even reinsurance, even health insurance reimbursement, allocation of healthcare dollars is all based on the idea that we need to define people as having the disease or not. So for the next bit, I'm going to talk about the importance of epidemiologic studies to inform screening and diagnostic cut points in diabetes. So when we think about the validity of a diagnostic or screening test, we need to compare the test to some estimate of the underlying truth, typically what we refer to as a gold standard or a gold standard test. One issue in diabetes is that we don't have any true gold standards. There's not a biopsy that we can do to determine if someone has diabetes. Our tests for defining diabetes are imperfect. And so, in complicating this is that type 2 diabetes has a gradual onset with glucose rising over time. So a useful standard or useful gold standard for thinking about screening and diagnosis is actually complications. In diabetes, complications can be very useful, quote unquote, gold standard. So, and the complications we can talk about are microvascular complications or small vessel disease, and those are most specific to diabetes. Whereas macrovascular complications or large vessel disease are less specific to diabetes, but are more common and often more deadly. So early studies by Harry Keene and others starting in the 1970s and 80s demonstrated a high prevalence of complications in people with diabetes before the onset of symptoms. And that really supplanted the notion that we should wait for people to become symptomatic before we diagnose diabetes. Important epidemiologic data in the 1990s showed that there were levels of glycemia where there was little prevalent retinopathy and above which retinopathy started increasing. And retinopathy is one of the most important small vessel diseases that occur in diabetes. And these data on retinopathy were used to define diagnostic cut points. And in 1997, diagnostic criteria were lowered from a glucose of 140 milligrams per deciliter to a fasting glucose of 125 milligrams per deciliter for the diagnosis of diabetes. And these are the 1997 criteria for diagnosis of diabetes, which recommended fasting glucose of 126 milligrams a deciliter or higher, a random glucose of 200 or higher with symptoms, or a 2-hour glucose of 200 milligrams or higher for the diagnosis of diabetes. And some of these are some of the important data that inform these diagnostic criteria. So shown here are 3 different studies. And what these data showed is that according to deciles of fasting glucose, 2-hour glucose, and hemoglobin A1C, there was a pattern where at low levels of these glycemic biomarkers, there was very little retinopathy, very low prevalence of retinopathy. But at high levels, we start seeing lots of retinopathy. And this pattern was shown in these different populations. And these data have been highly influential in informing diagnostic guidelines for diabetes. So historically, glycemic cut points have been based on these known associations with retinopathy. We also know from clinical trials that lowering hemoglobin A1C can prevent small vessel disease, and these trials have formed the basis of the use of hemoglobin A1C for monitoring and guiding treatment in diabetes for many years. So for decades, glucose was the standard for diagnosis of diabetes. So hemoglobin A1C has not historically been used for the diagnosis of diabetes. It was recommended for the determination of glucose control among those people with diagnosed diabetes. And some of this has to do historically with a lack of standardization of the hemoglobin A1C assay. And thanks to the National Glycohemoglobin Standardization Program, by 2005 or so, the hemoglobin A1C assays were very well standardized across the U.S., opening the door to discussions about the use of hemoglobin A1C for the diagnosis of diabetes. So when I began working in this area, the paradigm was that glucose is best for diagnosis of diabetes. Hemoglobin A1C should not be used for diagnosis, should only be used for monitoring glucose control. So I'm going to show you data challenging this paradigm and demonstrating that hemoglobin A1C is a powerful test that can have many advantages over glucose for diagnosis. So these are some of the advantages of hemoglobin A1C for diagnosis of diabetes. As I showed you on one of the early slides, it has much less biologic variability or within-person variability compared to fasting or 2-hour glucose. It's this index of overall glycemic exposure. The assay is now as well standardized as glucose. Hemoglobin A1C is also a non-fasting measure, so it eliminates the need for a person to come to the physician's office in the fasting state. Hemoglobin A1C, because it's this overall measure of glycemic exposure, is relatively unaffected by acute factors like physical activity, medication use, unlike fasting glucose. And as I mentioned, it's already been used for many years to guide and adjust treatment in the setting of the diagnosis of diabetes. So in 2009, an international expert panel first recommended the use of hemoglobin A1C for diagnosis of diabetes. And on the basis of data on retinopathy, you'll recognize this figure here. This is from this report, and the authors showed that hemoglobin A1C was strongly associated with retinopathy in pooled data from several different sources, and they recommended a hemoglobin A1C of 6.5% as the optimal cut point for defining diabetes, largely on this basis of the association with retinopathy. So in January 2010, in a major change to clinical practice guidelines, the American Diabetes Association first recommended the use of hemoglobin A1C for diagnosis of diabetes. You can see here, these are the criteria from the 2010 guidelines, and hemoglobin A1C was added to the list of criteria that could be used to make a diagnosis of diabetes. So along with fasting glucose, 2-hour glucose, and random glucose in the setting of symptoms, hemoglobin A1C was added to our criteria for the diagnosis of diabetes. And this recommendation was subsequently adopted by the World Health Organization and at this point many other, all of the other major diabetes international groups. So guidelines have been focused on epidemiologic data showing the association of tests of glycemia with retinopathy. But is retinopathy really the optimal gold standard? It's used because it's very specific to diabetes. But what about other outcomes? I think other outcomes are also important in thinking about optimal cut points and criteria for the diagnosis of diabetes. So as I mentioned, retinopathy is very specific, but the vast majority of deaths and hospitalizations in diabetes are from cardiovascular disease. So how can epidemiology be useful here? Well, long-term follow-up for major causes of morbidity and mortality can be really useful for informing diagnostic cut points. And at the time I became interested in this issue, there were actually very few data on hemoglobin A1C and long-term outcomes in persons without a prior diagnosis of diabetes. And that's because until 2010, hemoglobin A1C was only recommended for use in people with a diagnosis of diabetes. I'm very fortunate to be an investigator of the Atherosclerosis Risk in Community Study, or ARIC study. And we published this study in 2010 using biospecimens and data from the ARIC cohort. This was a major collaboration with my colleagues at Johns Hopkins, especially Joe Korish, and my late mentor, Fred Brancati, who unfortunately died of ALS in 2013. And worked closely with both Fred and Joe and also Mike Steffes, who is at the University of Minnesota, to measure hemoglobin A1C in all participants in the ARIC cohort. And Mike is a clinical chemist and a world expert in the measurement of hemoglobin A1C. And it was just a tremendously wonderful experience working with everybody to make this happen. So we found that persons with a hemoglobin A1C greater than or equal to 6% were at high risk for the development of diabetes, cardiovascular disease, and also death. This study demonstrated that hemoglobin A1C is not only a useful marker to identify people at risk for diabetes, but also for cardiovascular disease and mortality. We found that hemoglobin A1C was superior to fasting glucose for the assessment of long-term prognosis, and this work established the link between hemoglobin A1C and future vascular risk in an initially non-diabetic population, providing evidence to help support the use of hemoglobin A1C as a diagnostic test. So this work added to our understanding of the advantages of hemoglobin A1C for diagnosis of diabetes, demonstrating that it was associated with major clinical outcomes and had stronger associations than fasting glucose. So I'm next going to turn our attention to another issue related to the diagnosis of diabetes, and that is the implications of variability in these different measures of hyperglycemia. So until recently, clinical guidelines recommended a second blood draw to confirm the diagnosis of diabetes. I'm going to show you some of our work that challenged this paradigm and demonstrated a more efficient approach to the diagnosis of diabetes than having this second visit and this second blood draw. So here again are the 2010 criteria for the diagnosis of diabetes. I want to draw your attention to this footnote here at the bottom, and it says that in the absence of unequivocal hyperglycemia, any elevated test, any one of these elevated tests should be confirmed by repeat testing. And until 2019, ADA clinical practice guidelines recommended repeat testing of the same test in a new blood sample at a second time point. So the idea being that this is to reduce the possibility of a false positive diagnosis. But this recommendation also meant that patients had to have a second visit and a second blood draw, which is associated with a high burden and could result in loss to follow-up among many individuals. It's common for two different tests, such as hemoglobin A1C and glucose, to be measured in the same blood sample. But at the time, it was unclear if a combination of hemoglobin A1C and fasting glucose at a single time point would provide adequate confirmation for the diagnosis of diabetes. We published this work in 2018 examining the prognostic implications of a single sample confirmatory testing approach to identify diabetes, and again using data from the ERIC study. We found that measuring hemoglobin A1C and fasting glucose simultaneously in the same blood sample provided adequate confirmation for the diagnosis of diabetes. So this approach had a very high positive predictive value for the future diagnosis of diabetes and was also strongly associated with other complications, so future development of coronary heart disease, chronic kidney disease, and mortality. So this approach of measuring hemoglobin A1C and fasting glucose at one time point in a single blood sample represents a streamlined approach for diagnosis of diabetes, especially since hemoglobin A1C is already used to guide treatment decisions. Any single elevations or unconfirmed cases could be followed up with a second visit as per previous guidelines and current guidelines. So our results suggest also that if the tests have sizable discordance, this may suggest an issue that can warrant for further follow-up. So on the basis of this work, 2019 guidelines for the diagnosis of diabetes were revised. Current guidelines now state that the diagnosis of diabetes can be made on the basis of a combination of hemoglobin A1C and fasting glucose in a single blood sample. So here's text from the 2019 guidelines, which state that unless there's a clear clinical diagnosis requires two abnormal test results. Hemoglobin A1C and fasting glucose measured in a single blood sample provide adequate confirmation for the diagnosis of diabetes. So for the last bit, I want to talk about another issue related to the variability in measurements of hyperglycemia. So specifically, the implications of this variability for estimating the prevalence of diabetes. So it is commonly stated, and I've seen this in many different presentations, that 1/3 of cases of diabetes in the US are undiagnosed. But this is not true. And I'll show you some data demonstrating that only a small proportion of persons with diabetes are undiagnosed. So you'll remember from the beginning of the talk that I showed the high variability in 2-hour glucose and fasting glucose, especially relative to hemoglobin A1C. So, and you'll recall from the guidelines that all cases of diabetes require confirmation for diagnosis. So, and that, again, that's because we want to make sure we're not capturing false positive cases. We want to confirm that diagnosis to increase the specificity of the diagnostic approach. If only a single measurement is used to define diabetes, then prevalence estimates will actually be inflated. So as it turns out, conventional epidemiologic definitions typically do not use confirmatory definitions of diabetes. So the prevalence of undiagnosed diabetes in most epidemiologic studies is substantially overestimated. So 3 to 4 times higher in most epidemiologic studies compared to what we would see if we applied clinical practice definitions. And so this has really important implications for estimating the percentage of cases of diabetes in the United States that's undiagnosed. And this proportion of cases of total diabetes that are undiagnosed is a critical measure for monitoring how we are doing with screening and diagnosing diabetes. Because if there's a large proportion of cases that are undiagnosed, this suggests we're doing a poor job of screening and diagnosis. Where if there's a small proportion that's undiagnosed, that suggests most cases of diabetes are being captured by our current screening and diagnostic practices. So there's this paradox or dichotomy of the definitions being used in epidemiologic literature and what's actually happening in clinical practice. So what can we do to address this issue? So to solve this issue, to address this issue, we can repeat measurements to confirm cases and use definitions that most closely approximate clinical practice. So here are the conventional definitions of undiagnosed diabetes that are typically used in most epidemiologic studies, including most of our prevalence studies. So these non-confirmatory definitions, I'll call them, which are in widespread use, are typically defining undiagnosed diabetes by a elevated fasting glucose, a single elevated fasting glucose, or a single elevated hemoglobin A1C, or a single elevated 2-hour glucose. And in fact, many studies combine all three, sort of making the problem even worse, saying if you have a single elevated fasting glucose or a single elevated hemoglobin A1C or a single elevated 2-hour glucose, then we're going to classify these individuals as having diabetes. And that's entirely inconsistent with how we define diabetes in clinical practice. In clinical practice, we're using confirmatory definitions, and these have typically not been used in prior epidemiologic studies. So confirmatory definitions would look like a fasting glucose, an elevated fasting glucose, and an elevated hemoglobin A1C, or a fasting glucose measured at 2 different time points and defining the diabetes on the basis of those 2 elevations. And similarly, measuring hemoglobin A1C at 2 separate time points and defining diabetes on the basis of those 2 elevations. So we undertook a study to look at prevalence of diabetes using a confirmatory definition. And just to give you some idea of the magnitude of the issue, these are estimates of the total prevalence of diabetes using the same data but using 2 different approaches. So diagnosed cases are on the top of these 2 bar graphs, and that doesn't change. This is based on the proportion of individuals in the total U.S. population who say they have had a physician diagnose them with diabetes. So that's the same in these 2 figures. On the left, I'm showing you a typical estimate of the total prevalence of diabetes in the U.S., and again, using the same data source in the 2 different populations using national data. And in this figure on the left, 36% of the total cases of diabetes are undiagnosed using an unconfirmed definition. So this is defining undiagnosed diabetes using any elevated test. So an elevated fasting glucose or an elevated hemoglobin A1C or an elevated 2-hour glucose. And so using that approach, 36% of total diabetes cases are undiagnosed. So when you use a confirmatory definition, and in this case, using an elevated A1C confirmed with an elevated fasting glucose, we only have 11% of total diabetes cases that are undiagnosed. So a huge difference in the estimate of the proportion of total cases of diabetes that are undiagnosed if we use unconfirmed versus a confirmed definition. And this really has important public health implications. This suggests we're not doing a very good job with screening and diagnosis. Suggests that 1 out of 3 people who have diabetes are walking around without a diagnosis. Whereas here, if we use a definition that is more consistent with clinical practice, it suggests that the vast majority of cases of diabetes are recognized and identified in clinical practice. So this is just showing you the same data, but showing you trends over time. Excuse me. So the top row here again is diagnosed cases, and you can see the vast majority of cases of diabetes in the U.S. are diagnosed. And then the prevalence of undiagnosed diabetes is shown down here in this black bar using a confirmatory definition. And so you can see that diabetes prevalence, as we know, is increasing overall in the population. But as a proportion, undiagnosed diabetes, as a total is going down. So the proportion of cases that are undiagnosed has actually decreased over time, suggesting we're doing a good job with screening and diagnosis in the United States. So what does this all mean? This means of the 25.5 million adults in the U.S. Who have diabetes, only about 11% are undiagnosed. And this estimate reflects the strict application of clinical guidelines to national data from the National Health and Examination Interview Survey to most accurately estimate the proportion of persons with undiagnosed diabetes in the U.S. And so using this approach, our findings are actually in stark contrast to previously published national estimates, which state that 25% to 35% of cases of diabetes in the U.S. are undiagnosed. So to conclude from some of this research, using data from the ERIC cohort, we established the link between hemoglobin A1C and future vascular risk, informing the use of hemoglobin A1C for diagnosis. We also showed that 2 tests from the same blood sample provide adequate confirmation for the diagnosis of diabetes. And then finally, we also demonstrated that epidemiologic definitions of undiagnosed diabetes that are in widespread use are not consistent with clinical practice. And to address this issue, we can simply use definitions that more closely approximate clinical practice. And when we do this, the data show that we're actually doing an excellent job of screening and diagnosing diabetes in the U.S. So I think my final message to you is that for risk factors along the continuum, separation from disease from non-disease can be inherently somewhat arbitrary, is often intensely political, but should be informed by the best available evidence, and epidemiologic studies have an incredibly important role to play in doing this. Epidemiology is a team science. I have an absolutely amazing team. I would like to thank all my co-authors, all my collaborators on these projects, but I'd particularly like to thank the staff and participants of the ERIC study without whom none of this work would be possible. I want to thank you all very much for joining this webinar, and I am happy to take any questions that you may have. Thank you very much.
Thank you, Dr. Selvin. We've had lots of questions rolling in during the webinar, many related to technical measurement issues. Maybe we'll start with some of those and then move on to some of the more general things. You showed a 2-week coefficient of variation for glucose early on, and it was about 6% or so. Was that for fasting glucose? That's the question.
That was for fasting glucose, yes.
Okay. Is it true that for most who progress to type 2 diabetes, the 2-hour post-load is the first marker to become abnormal, which would suggest that the HbA1c is next and maybe fasting glucose becomes abnormal last? Is that the usual sequence?
Yeah, I don't think we really have rigorous data to answer that question. I think it's an important question, sort of which elevation, which disorder do we see first? One issue with the 2-hour glucose is, maybe it's more sensitive, but it also has this tremendously high variability. So it means if I undergo a 2-hour glucose tolerance test today, my result may be quite different if I undergo a second one several weeks from now. So that's a real concern with the test. It's also very burdensome. Speaking as someone who's undergone a 3-hour oral glucose tolerance test, it's a really unpleasant test. I think that should be considered when we think about both screening and diagnosis. And then I think the third point is that when we're making treatment decisions, we're making them on the basis of hemoglobin A1C. So having the hemoglobin A1C in front of you when you're making the diagnosis of diabetes is actually really central to thinking about what next, what steps do I take in terms of recommendations to that patient and thinking about interventions.
Thank you. You've pointed out that the current recommendations call for 2 tests, and it's often HbA1c and fasting glucose. How much better does the pair of those tests do than just the HbA1c alone?
Yeah, that's a great question. So you get a little bit, more of a boost when you have that elevated glucose because it's adding some specificity to the whole testing process. So a combination of fasting glucose and A1C will be more specific than a single A1C alone. I think that sort of quote-unquote boost is fairly marginal. I think, using a single hemoglobin A1C will probably get you most of the way there. There are certain conditions in which hemoglobin A1C is potentially problematic. So There's most hemoglobin variants are not an issue with modern hemoglobin A1C assays, but it depends somewhat on which assay is being used and which hemoglobin variant we're talking about. And the NGSP website, ngsp.org, has a really great discussion and maps out all of those issues. So if there's a hemoglobin variant, and with certain assays, the hemoglobin A1C result may be inaccurate. So there's some other conditions, in the setting of anemia or anything that alters red blood cell turnover, hemoglobin A1C could also be affected. So having that glucose, which is going to be unaffected by any hemoglobin variant, or anything that alters red cell turnover, having that additional glucose can provide some understanding of whether we're really talking about hyperglycemia. So, so when there's substantial discordance between the fasting glucose and the hemoglobin A1C, that's really informative in and of itself. So, I think it's intuitive that two tests are better than one, but I think having them both in front of you can solve a lot of concerns that have been raised about either test.
You showed us data that with the two tests involved, with the confirming, the proportion of undiagnosed cases is a lot lower than we might have thought previously. And you showed data that proportion has not been growing over time, that it's been fairly flat. What does it look like across racial and ethnic groups, or men and women? What about differences?
Yeah, that's a good question. There's, in terms of sex differences, there are some sex differences, again, but it's mostly in younger age. I think there are pockets of particularly men who are not seeing their doctor, pockets of obese individuals, specifically obese men, those individuals who don't have health insurance, and that, of course, also overlaps with socioeconomic status. So lower socioeconomic status, certain underrepresented minority groups, and where higher rates of lack of health insurance exist, we see pockets of higher prevalence of undiagnosed diabetes. And that suggests that instead of sort of a widespread strategy that, we're just doing a generally poor job of identifying people with diabetes, I think that's really not the case. What our data suggests that there's pockets of the population, particularly younger, obese, uninsured individuals, that should be targeted for screening, because that's where we're missing the cases of diabetes. It's a great question.
Are there implications for screening for and diagnosing prediabetes?
Yeah, so all of these issues sort of also play out in the setting of prediabetes. And the current prediabetes, you can invite me back. I'll give a whole other webinar on prediabetes.
We'll do that. We'll do that.
Prediabetes is a substantial interest of mine, and thinking about how we screen and diagnose prediabetes is really important. Currently, there are 5 different definitions of prediabetes that are in current clinical use on the basis of fasting glucose, 2-hour glucose, hemoglobin A1C, and no one definition is recommended over another. So the prevalence of prediabetes is going to vary tremendously depending on which definition is used. And so I think, and then also there's no single recommendation sort of how we identify people with prediabetes in the clinic. So I think that's created a lot of confusion in the field, that we have all these different definitions of prediabetes and no one definition is preferred over the other. So I think a challenge for the field is really to come together and think about some consensus definitions for prediabetes, because I don't think having 5 definitions is really doing anyone any favors. And then, unlike diabetes, there's no formal recommendation for confirming a diagnosis of prediabetes. So that's sort of an added level of uncertainty when we're thinking about prediabetes. I think prediabetes is really important. I think we need to identify people who are at high risk for the development of diabetes. And I think we need to come up with some consensus definitions to try to address some of these issues in the setting of prediabetes as well.
You've talked quite a bit about the way to do the testing, and how accurate it can be. How often should the screening test be conducted, the pair, either two HbA1cs or an HbA1c and a fasting glucose? Is that something that should be done every 6 months, every year, every 3 years?
Yeah,
and does that depend on age and other things?
Yeah, I mean, current guidelines are every 3 years starting especially over age 40 and in high-risk populations. So there's not much evidence that screening more than every 3 years is necessary unless someone has prediabetes and we really think that's a high-risk group.
We couldn't get through a webinar without a question about COVID-19. We have a question, what do you think the impact of COVID-19 is going to be on screening for diabetes? My guess is that there's going to be a lot less screening because there's a lot less of every kind of health care with COVID-19 unless it's related to COVID-19.
Yeah, so there's lots of big questions about diabetes and COVID-19, and I'm doing a little bit of work in this area. I think, the first question about screening, right, if people, we're seeing that, regular visits to the doctor and even acute admissions are way down, and that's certainly a concern that, because of the pandemic and because people are fearful and because of the high risk of transmission in certain medical facilities, this is a big issue. Children aren't getting their vaccines. People are certainly not getting screened for diabetes. So, I think that's a real, I think there's just general concerns for preventive medicine currently, and that's incredibly important. There's also the broader question of whether diabetes is a risk factor for poor prognosis among patients who are hospitalized for COVID-19, and there's some preliminary data that suggests that diabetes may be an important factor in the development of acute respiratory distress syndrome or mortality. But I think it's really, the jury is still out. We haven't really seen studies that have carefully controlled for age, sex, other comorbidities that are common in the setting of diabetes, like cardiovascular disease. And then also obesity. I think we're seeing, growing evidence that obesity is really important in this pandemic and in the prognosis of individuals who are diagnosed with COVID-19.
Do you think HbA1c is a good measure for gestational diabetes?
So hemoglobin A1c is not measured in the setting of pregnancy, and that's because of sort of two things. One is red blood cell turnover and blood volume issues, but also because hemoglobin A1c is a 2 to 3 month measure of hyperglycemia. So because the window of pregnancy is this short window, we really need to know what's going on in a more rapid fashion rather than having something that's only going to change every few months. So shorter term tests are recommended for monitoring glucose control in the setting of gestational diabetes. And then of course, the oral glucose tolerance test is still considered the gold standard for screening for gestational diabetes on the basis of the thinking that it is a much more sensitive test.
What about using HbA1c in folks who have blood disorders like sickle cell?
Yeah, so certainly sickle cell disease, you cannot use hemoglobin A1c. Sickle cell trait is much less of an issue. There is certainly some misinformation out there that has suggested that hemoglobin A1c can't be used in the setting of sickle cell trait. But most of the modern hemoglobin A1c assays are robust to any interference with sickle cell trait, and so that's typically not a major concern.
We have someone quoting CDC data reporting that CDC statistics state that 1 in 2 Asian Americans with diabetes are undiagnosed. Can you comment on that? Because your data suggested that failing to diagnose was much lower.
Yeah, so I would argue that actually the true prevalence of undiagnosed diabetes or unrecognized diabetes in the population is much lower. I haven't specifically looked in the Asian populations, but I would imagine that the depth, certainly worth looking at the definition being used, but certainly if the definition is a non-confirmatory definition, say a single elevated fasting glucose or a single elevated A1C, that's going to result in a higher prevalence than what we would see had those people gone to the doctor and received a diagnosis, because that's not a definition that's consistent with clinical practice.
Now, here's a very interesting methods question. If we're able to use HbA1c and fasting plasma glucose to get to the right proportion of undiagnosed diabetes, how does that impact generating trend charts where we only have the older estimates in our survey data, referring to older epidemiological data sets? Are we able to retrospectively recompute and get better estimates?
So if we have data like the National Health and Nutrition Examination Survey, where hemoglobin A1C is systematically measured in everybody, then we can do that, right? And we actually have done that. So we can go back and systematically look at, we can apply current days, current days definitions, current days diagnostic criteria to older data. So we can go back and do that. There's a little bit of a wrinkle in that the diagnosed cases are going to be based on the old criteria. So people that certainly would have been diagnosed in present day will not be diagnosed in those older data sets. So you'll have people who have a diagnosis, and that'll be based on the older criteria, and then we can certainly apply the newer criteria to those older data to get estimates of undiagnosed.
Interesting. Okay. A different method question. Does the time that passes between when the blood is drawn and when it's analyzed affect the assay?
So one nice thing about hemoglobin A1C is not so much. So hemoglobin A1C is analytically very stable. So really not much of a concern for hemoglobin A1C if things are getting processed fairly quickly. With glucose, it's a huge concern. So if the glucose isn't processed quickly, it's very labile. It has much greater analytic variability. So the glucose will, if it sits out, it's going to be too low in a sense. So that's one other issue in terms of thinking about glucose versus A1C. And in the setting of clinical practice, where if unlike our sort of standardized studies like ERIC and NHANES, where things are processed very rapidly and efficiently and very standardized, in the clinic, that can be a major concern for inaccurate glucose testing.
We have a question about economic evaluations of the confirmatory diagnostic test that uses a single blood sample compared to two separate blood samples. I'm not sure I understand the question, but I'm sharing it with you in case it makes sense to you and you can answer it. So the question as posed, are you aware of any economic evaluations of the confirmatory diagnostic test that uses a single blood sample compared to two separate samples?
Yeah, so, I mean, I'm not aware of any formal cost-effectiveness analyses. I think, I presented and focused on epidemiologic data for informing screening and diagnosis. I'm an epidemiologist. There are obviously a lot of other studies and other types of studies that are really important in our thinking about diagnostic criteria, including cost-effectiveness analyses. So I think in general, that's a really great question. Specifically, I think there's a number of different parameters that would go into that equation. First, so glucose is super cheap, super easy to get, and really incredibly inexpensive. It's hard to get out of the doctor's office without having your glucose measured. There is the issue of whether people are fasting, right? So it's much harder to get a fasting sample. You're not going to get a fasting sample in the afternoon or evening. So it means people have to be prepared for the visit and come in fasting. So that has a certain sort of non-monetary cost. And if people don't come in fasting, you're having them come back for a second visit in the fasting state certainly has a cost. Hemoglobin A1C is a more expensive test than fasting glucose. So that's certainly a concern, especially in resource-poor areas where hemoglobin A1C may be cost inefficient. Certainly from a general cost effectiveness standpoint, being able to make a diagnosis at a single visit on the basis of a fasting glucose and a hemoglobin A1C right then and there, and not having someone come back for a second visit several weeks later is highly efficient. So I think that's one of the reasons I felt that doing that analysis and getting the guidelines to change was really critical, because I think it represents a very efficient way to diagnose diabetes. And there's certain populations where you may ask the person to come back, and you're going to lose patients. You're going to lose high-risk individuals who may not return for that second visit, so you could miss cases. So there's no formal cost-effective analyses that have been done. They certainly should be, but I think in certain circumstances, it's certainly a very efficient approach.
A very different kind of question. What do we know about the relationship between variability in the gut microbiome and HbA1c?
Me personally, basically nothing. I know that gut microbiome is very interesting and important, kind of a hot topic. I think, my understanding or general reading of the literature is we really don't quite know anything yet. There's certainly lots of promise and interest of the role of the gut biome in diabetes. I don't know of any specific data on hemoglobin A1C, though.
Okay. Since we are the Office of Disease Prevention, I can't get through this series of questions without asking you for thoughts on prevention strategies. So what advice would you offer in terms of preventing diabetes? What can people do in terms of diet, weight, physical activity, smoking, other lifestyle factors?
So all of the things you listed, certainly incredibly important. I think, two messages that are really important. One is that even modest weight loss can have a major effect on diabetes risk. So even, 5% weight loss can have a big effect on risk of diabetes. We know that from the DPP trial. So I think, focusing on weight loss, but noting to patients that even modest weight loss can be incredibly important. I think another area that has not received sufficient attention is just preventing weight gain, right? So, there's enormous numbers of people in the population who have prediabetes, who are at risk for the development of diabetes. And, on average, adults are gaining weight every year in the population. So figuring how not just weight loss strategies, but also just preventing weight gain, I think is also very important in thinking about prevention and diabetes prevention and intervening in the setting of prediabetes.
What about folks who already have diabetes? Are some of those same actions going to be helpful?
Yeah, absolutely. So, major lifestyle changes, so weight loss, increasing physical activity, all of these things are incredibly important and can make a huge difference in glycemic control in the setting of diabetes.
And we have someone asking, since we're talking about preventing, are we talking about type 2 only or type 1 and 2?
So I'm talking only about type 2 diabetes. But there is growing recognition that obesity and insulin resistance is also an issue in type 1 diabetes. One of the things about type 1 diabetes that's incredible is that the technology has made it such that individuals with type 1 diabetes are living longer than they ever have in the history of humankind. And so now we're seeing these chronic disease issues like obesity, insulin resistance in the setting of type 1 diabetes. And I think that's also an important public health concern and a clinical concern in the setting of treatment of people with type 1 diabetes.
Thank you. Are you aware of progress towards an HbA1c test that could be done at home?
Yeah, so that's a really controversial issue. So there are lots of point of care A1C tests. They are not currently recommended for the use for diagnosis. They're typically being used in a clinical practice setting, not for home use. So, and that's sort of a complicated political regulatory issue, and there's just concerns about standardization of those assays. So some of them are quite good, and some are not so good. And so figuring out how to standardize and certify point of care testing is also an important and big controversy in the field presently. So currently, point of care A1C testings are not recommended for use for diagnosis.
And we'll see how that evolves over time. Here's a question. What proportion of the pre-diabetic group can be defined by gestational diabetes, and how do these rates differ by obesity status?
Yeah, I mean, I don't know the numbers off the top of my head. Certainly gestational diabetes is very important risk factor for both prediabetes and the subsequent development of diabetes. So, one of the things that I think from a prevention standpoint is recognizing that gestational diabetes and that for individuals who have gestational diabetes, that postpartum period is an opportunity to do diabetes prevention. And I think often, with respect to gestational diabetes and for pregnant women following pregnancy, the focus is on the baby, the focus is on pediatrician visits, and often I think the preventive health in the mom is not a sufficient emphasis. And I think figuring out how to do those pediatrician and well baby visits and worrying about the health of the baby in concert with thinking about the health of the mom could be highly efficient and really important for prevention of diabetes, but also just cardiometabolic risk in general, because the same thing is true with preeclampsia and hypertension in pregnancy as well. All of those metabolic risks that occur during pregnancy don't just magically disappear once there's a baby. So thinking about how to do prevention following pregnancy, I think, is really important.
Let me ask if you have any closing thoughts that you'd like to share with the group. You've been answering questions rapid fire here for 25 minutes, quite remarkable. Do you have any closing thoughts that you would like to share with our audience?
No, this has been really fun. I love the questions. I do a lot of teaching. I think the questions are the best part. I'm glad that people are online and paying attention. These have all been wonderful questions and an opportunity to really have a discussion, which I appreciate. I just thank you for this opportunity. This has been really fun.
Well, you've done a terrific job. I will turn things back to Dr. Oyedele.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and recording of today's session on our website next week. You will receive an email with a link to the recording when it is available. Thank you.